I'd like to thank the organizers of the 39th Annual Meeting of the Japanese Society for AIDS Research for the invitation to speak today. It is an honor to participate in this meeting. I would also like to apologize for not being able to join you in person. Due to scheduling constraints, I am presenting this talk remotely, but I am very pleased to be able to share these updates with you. In this presentation, I will provide an overview of the changing landscape of HIV drug resistance, highlighting recent developments and their implications for clinical practice and public health. I have no disclosures. I'm going to structure my talk in three parts. First, I'll review pre-therapy drug resistance, including both transmitted resistance and resistance emerging in people who acquire HIV while taking PrEP. Second, I'll cover acquired drug resistance with a particular focus on dolutegravir. More than 25 million people worldwide are now receiving a dolutegravir-based regimen, so understanding the prevalence and risk factors for dolutegravir resistance is critical. Finally, I'll discuss some aspects of modifying therapy in people with virological suppression. This section will focus on the role of proviral DNA resistance testing, a brief discussion of long-acting cabotegravir rilpivirine, and a discussion of emerging data on using broadly neutralizing antibodies as components of long-acting therapy. Over the past decade in high-income countries, and over the past 5 years in many low and middle-income countries, the widespread adoption of second-generation INSTIs has dramatically reduced the clinical importance of transmitted drug resistance. The main reason is that transmitted INSTI resistance has consistently remained below 1%, even as the use of dolutegravir and bictegravir has expanded globally. Transmitted NRTI resistance has generally been below 5%, but many of the transmitted NRTI resistance mutations are not relevant to tenofovir and the cytosine analogs 3TC and FTC. Transmitted NNRTI resistance has remained above 10%, but only a small proportion of these mutations are relevant to current NNRTIs. What's notable is that these trends are remarkably similar in both high-income and LMIC settings. This slide summarizes data from the largest U.S. study of transmitted drug resistance published by the CDC in 2022. It includes resistance results for more than a large proportion of newly diagnosed persons between 2014 and 2018. Several smaller, more recent European studies from the same period have shown very similar patterns of transmitted drug resistance mutations. First, transmitted INSTI resistance was extremely low, just under 1%, with no single mutation exceeding 0.2%. Second, NRTI resistance was also low, with only about 1% carrying M184VI or other relevant mutations to currently used NRTIs. TAMs were observed, but usually in patterns unlikely to compromise modern regimens. Third, NNRTI resistance remained common at around 12% overall, but the mutations relevant to today's NNRTIs were far less frequent. Rilpivirine resistance was about 2.5% cumulatively, and doravirine resistance was under 1%. The U.S. Public Health Service guidelines still recommend baseline resistance testing, but these data illustrate that the risk of virological failure due to transmitter resistance is far lower today than prior to the use of second-generation INSTIs. Even so, pre-treatment resistance testing remains important when considering two drug regimens like dolutegravir 3TC or cabotegravir-rilpivirine, where transmitted mutations, though uncommon, can have a larger clinical impact. Two large studies were presented this past year from the two major U.S. reference laboratories, each analyzing resistance data from roughly 100,000 patients with samples collected between 2018 and 2024. Because these laboratories did not have access to treatment histories, it was not possible to distinguish between transmitted and acquired drug resistance. The LabCorp study shown in the figure on the right found that resistance levels were remarkably stable across all drug classes during the 6-year period. In contrast, the Quest diagnostic study, not shown on this slide, reported slightly declining resistance trends, including a modest drop in INSTI resistance from 6.5% to 5.1% over time. One of the main factors shaping which resistance mutations we see in untreated patients is replicative fitness. Mutations with a high fitness cost tend to disappear quickly after transmission because they are outcompeted by wild-type revertants, making them less likely to be detected and less likely to be transmitted. Two studies from 2011 and 2013 followed people with acute or recent HIV infection for several years before they started ART. These cohorts allowed us to see how long transmitted drug resistance mutations persist in the absence of treatment. The left figure shows that high-cost mutations like M184V fade rapidly. Within 2 years, they remain detectable in only about 1/3 of individuals. By contrast, many TAMs and NNRTI resistance mutations persist for much longer, as reflected in the table on the right, where some mutations have median persistence times of 6 to 9 years. The table on the far right links persistence to transmission. Mutations that fade quickly, such as K65R or M184V, rarely appear in transmission clusters, while long-lasting mutations, such as 103N or 215 revertants, cluster far more frequently. Overall, these data show that drug resistance mutations with poor fitness are detected less often and transmitted less often, while fitter mutations persist and propagate more readily. Finally, pre-therapy drug resistance is more common in people who acquire HIV while taking PrEP. Most of the data come from individuals taking tenofovir FTC, summarized in the WHO meta-analysis shown here. Across cohorts, about 20% of people who seroconvert on PrEP have M184VI, while only about 1% have K65R. Breakthrough infections are far less common with cabotegravir or lenacapavir, but the risk of emergent resistance is high when breakthrough does occur, as seen in HPTN 083 for cabotegravir and in PURPOSE 2 for lenacapavir. In all three settings, the highest risk of both breakthrough and emergent resistance occurred when PrEP was started during undiagnosed acute infection. For this reason, when a patient acquires HIV while on PrEP, genotypic resistance testing is much more likely to detect resistance compared to typical pre-treatment cases. I'm going to now transition to acquired HIV drug resistance. Multiple trials and meta-analyses have shown that TLD is more effective and more durable than the older regimen of tenofovir 3TC efavirenz, or TLE. In addition, a key difference between the two regimens is what happens when virological failure occurs. People who develop virological failure on TLE are much more likely to develop drug resistance. In contrast, people who develop virological failure on TLD are far less likely to have drug resistance, and more often failure is due to non-adherence. This distinction shows up in resuppression data. Individuals with virological failure on TLD are twice as likely to suppress with enhanced adherence counseling compared with those failing TLE, 66% versus 32%. That reinforces that most episodes of virological failure on TLD do not result from dolutegravir resistance. Because of its higher efficacy and higher genetic barrier, TLD has been recommended for people who previously received TLE, whether they have transitioned from TLE while virologically suppressed, or whether they switched to TLD after virological failure on TLE. Last year, we published a systematic review of acquired drug resistance across 43 clinical trials, which are summarized in this table. These studies fall into 6 clinical scenarios. The first 2 scenarios, highlighted in blue, include ART-naive participants receiving either dolutegravir plus 2 NRTIs or dolutegravir 3TC. Scenario number 3 includes ART-experienced individuals with a history of virological failure on an NNRTI-based regimen who were switched to dolutegravir plus 2 NRTIs. Scenarios 4 to 6 represent participants with stable virologic suppression who were switched to a dolutegravir-based simplification regimen, either dolutegravir plus 2 NRTIs, dolutegravir plus a second antiretroviral, or dolutegravir monotherapy. Across trials, the risk of developing dolutegravir resistance was 0 or close to 0% over 48 to 96 weeks in ART-naive participants and in stably suppressed participants who remained on dolutegravir plus at least one additional active antiretroviral. However, 2 scenarios stand out. In participants with virological failure who were switched to dolutegravir plus 2 NRTIs, the risk of emergent dolutegravir resistance over 96 weeks was 1.5%, and in stably suppressed individuals who were placed on dolutegravir monotherapy, the risk was substantially higher, 3.4%, within just 24 to 48 weeks. Outside of clinical trials, the risk of acquired dolutegravir resistance is substantially higher. On the left is a summary of 4 U.S. PEPFAR-supported cross-sectional surveys conducted between 2020 and 2022. Across these surveys, the prevalence of dolutegravir resistance ranged from about 4% to nearly 20%. Much of the variation likely reflected differences in treatment history, particularly the proportion of individuals who switched to TLD while virologically suppressed versus those who were already failing therapy. 2 more recent cohort studies have reported even higher rates of dolutegravir resistance. The DTG Resist study, conducted in 7 African countries, found that 26% of 227 patients with a virus load greater than 1,000 copies per mil had at least one dolutegravir-associated drug resistance mutation. A South African cohort found even higher rates of dolutegravir resistance, 63% of 59 individuals, likely reflecting a longer duration of virological failure and the fact participants were screened for adherence, leading to a population enriched for individuals with prolonged ongoing failure on dolutegravir. Taken together, these data highlight that in real-world settings, especially where patients transition from failing NNRTI-based regimens, the emergence of dolutegravir resistance mutations occurs frequently. This slide shows the four main mutational pathways selected by dolutegravir in INSTI-naive individuals: R263K, G118R, Q148HKR, and N155H. Nearly 90% of all isolates with dolutegravir resistance had one of these four signature mutations, and only 12% had more than one, reflecting the fact that these pathways are largely mutually exclusive. Each panel shows how often the signature mutation appeared alone and how often it appeared with another signature mutation, which was uncommon, and the accessory mutations that tend to accompany that pathway, with the bolder one showing statistically significant associations. This slide summarizes in vitro dolutegravir susceptibility data associated with each of the four major signature mutations. G118R produces the largest reduction in dolutegravir susceptibility. When present alone, it causes about a 9-fold decrease in susceptibility, and the effect is even greater when combined with accessory mutations, typically reaching double-digit fold changes. In contrast, R263K has a modest effect. By itself, it reduces susceptibility only about 2-fold, and even in combination with additional drug resistance mutations, most values remain below 7-fold. N155H alone has a minimal impact, and substantial reductions in susceptibility occur only when it appears with multiple accessory mutations. Finally, the Q148HRK pathway shows a stepwise pattern. Q148 alone has little or no effect on dolutegravir susceptibility. With one accessory mutation, susceptibility decreases roughly 4-fold. With 2 or more accessory mutations, the reduction increases to around 10-fold, with some values reaching much higher levels. Overall, these data emphasize that G118R and complex Q148 pathways pose the greatest risk for clinically significant dolutegravir resistance, whereas R263K and N155H alone usually occur only low-level decreases in susceptibility. This slide summarizes how integrase inhibitor resistance patterns affect cross-susceptibility among the 3 second-generation INSTIs. Across all 3 scatter plots, you can see strong linear relationships between the susceptibility values. The Spearman correlations range from about 0.67 to 0.80, indicating a high degree of cross-resistance. The slopes provide insight into relative susceptibility. In the DTG versus BIC panel, the slope is 0.75, suggesting that BIC tends to retain slightly more activity than DTG for a given resistance profile. In the CAB versus DTG panel, the slope is 0.61, indicating that CAB susceptibility usually drops slightly more than DTG when drug resistance mutations accumulate. In the CAB versus bictegravir panel, there's a slope of 0.52, again highlighting that CAB is generally the most affected when resistance occurs. A large proportion of persons with HIV with virological failure on dolutegravir, even those with documented adherence, do not have INSTI resistance mutations. Several studies now show that mutations outside of integrase in the polypurine tract, in envelope, and in the nucleocapsid can reduce INSTI susceptibility. Envelope and nucleocapsid, or NC, mutations often arise earlier than integrase mutations in dolutegravir passage experiments, but we have very limited data on how often these mutations occur in patients. Envelope mutations can reduce INSTI susceptibility by increasing the multiplicity of infection through enhanced cell-to-cell spread. These envelope mutations reduce susceptibility to multiple ARV classes, but they also may make viruses less capable of cell-free transmission. NC mutations appear to speed up the transition from reverse transcription to integration, shortening the window in which INSTIs can act. If these pathways turn out to be common clinically, it will raise two important questions. First, should we sequence beyond POL in patients who fail dolutegravir without integrase drug resistance mutations? Second, for patients with integrase mutations, are we underestimating the true level of resistance because of additional envelope or nucleocapsid mutations are present? They may further reduce dolutegravir susceptibility. One of the central challenges in managing virological failure on TLD in LMICs is that genotypic resistance testing is not routinely available. As a result, it is often difficult to distinguish non-adherence, which is more common, from dolutegravir resistance. This distinction matters clinically and economically. If failure is driven by poor adherence, switching empirically to a much more expensive regimen like darunavir-ritonavir may provide no benefit. But if failure is driven by dolutegravir resistance, keeping the same regimen risks continued viremia. A recent modeling study suggests that targeted use of HIV drug resistance testing for individuals with sustained virus load non-suppression may be cost-effective even in resource-limited settings. This model assumed annual costs of roughly $20 to $40 for dolutegravir, $210 for darunavir, and $200 for genotypic testing. Two ongoing strategy trials are designed to guide decision-making. The RESOLVE trial is evaluating whether patients with persistent viremia on TLD should be switched immediately to darunavir or managed with individualized care, including resistance testing and adherence assays based on measuring tenofovir levels. The NADOVU trial is enrolling people with dolutegravir-associated mutations and comparing outcomes on continued dolutegravir versus switching to darunavir. The diagnostic challenges posed by virological failure on TLD, together with new analyses suggesting that genotypic resistance testing may be cost-effective in certain settings, prompted the WHO to publish a target product profile to encourage diagnostic manufacturers to develop HIV drug resistance tests for LMIC use. The primary use case outlined in the TPP is sustained virus load non-suppression in patients receiving TLD. Additional use cases include heavily treatment-experienced patients with confirmed virological failure after exposure to 3 or more drug classes, and children who have a higher prevalence of HIV drug resistance due to perinatally transmitted resistance and fewer available treatment options. The TPP also addresses PrEP breakthrough infections, which may involve resistant virus. In response to these needs, the WHO envisions the development of both sequencing-based tests and less expensive point mutation assays, each suited to different clinical and programmatic contexts. As part of these efforts, I have been collaborating with the WHO to create a tiered ranking of HIV drug resistance mutations designed to guide assay developers by prioritizing mutations based on their frequency and clinical impact on drug susceptibility. I'm going to move on now to treatment simplification in persons with HIV with stable virological suppression. HIV treatment options are increasingly being developed for people with stable virological suppression, typically defined as maintaining HIV-1 RNA levels less than 50 copies per mil for at least 6 months. 2 regimens are approved exclusively for individuals in this setting: long-acting cabotegravir/rilpivirine and oral dolutegravir/rilpivirine. A third option, doravirine/islatravir, will likely receive approval for this indication in early 2026. In addition, dolutegravir 3TC and bictegravir/taf-FTC are widely used both for treatment simplification and as first-line therapy, provided the patient has not previously failed an INSTI-based regimen. There are also several investigational simplification strategies, including lenacapavir/bictegravir, lenacapavir/islatravir, and combinations that pair cabotegravir or lenacapavir with broadly neutralizing antibodies. In the remainder of this talk, I'll focus on key aspects of cabotegravir/rilpivirine use and then provide an overview of emerging data on bNAbs as components of long-acting simplification therapy. As we move from transmitted and acquired resistance to the question of proviral DNA testing prior to treatment simplification, it's important to remember what the proviral reservoir actually looks like in people with long-term viral suppression. First, more than 90% of integrated proviral genomes are grossly defective, usually because of large deletions or because the virus has undergone extensive APOBEC-mediated G to A hypermutation. Second, an even larger fraction, over 99%, are non-inducible in culture. Many of these appear intact at the sequence level, but are replication incompetent because of subtle genetic defects or epigenetic silencing. Third, the total reservoir may look stable over time. That's because reactivation leads to the death of the host cell, while latently infected cells can expand through clonal proliferation, maintaining the apparent reservoir size. Finally, the part of the reservoir we care most about, the replication competent fraction, declines progressively with prolonged viral suppression, since intact proviruses are the ones most capable of reactivating and being eliminated. Proviral DNA genotypic resistance testing does not reliably capture all drug resistance mutations that may have emerged during prior episodes of virological failure. This slide illustrates 2 contrasting scenarios. In the first, episodes of virological failure, as shown here, were prolonged, allowing drug-resistant viruses to replicate for extended periods and seed a large fraction of the proviral reservoir. In this situation, proviral DNA testing is more likely to detect those historical drug resistance mutations. In the second scenario, shown here, episodes of virological failure were brief. Here, drug-resistant viruses may have existed only transiently and seeded the reservoir at very low levels, often below the detection threshold of proviral DNA testing. Consistent with this, multiple studies have shown that drug resistance mutations previously observed in plasma virus are sometimes absent in proviral DNA sequences. To improve sensitivity, proviral DNA assays typically rely on next-generation sequencing, which can detect variants present in fewer than 5% of proviruses. Whether undetectable or extremely low-level drug resistance mutations have the same clinical significance as detectable ones remains uncertain. Proviral DNA genotypic resistance testing can be confounded by mutations that result from APOBEC-mediated G to A hypermutation rather than from drug selection pressure. Roughly 16 recognized drug resistance mutations can arise within ApoBec3G or ApoBec3F dinucleotide contexts. I've listed the most clinically relevant of these ApoBec-associated drug resistance mutations on this slide. These mutations should be disregarded when the sequence shows evidence of G to A hypermutation, as they do not reflect true drug-selected resistance. There are three major analytic approaches for determining whether a sequence is hypermutated. The details are beyond the scope of this talk, and determining hypermutation status should be the responsibility of the sequencing laboratory. Importantly, mutations that are not known to arise through hypermutation should still be interpreted as valid resistance mutations, even when overall hypermutation is present. This slide summarizes the reported prevalence of virological failure with long-acting cabotegravir/rilpivirine across published studies. Across 33 studies, including more than 9,000 people, the prevalence of virological failure among patients who started cabotegravir/rilpivirine when they were virologically suppressed has been reported to be about 1%. In clinical trials, the virological failure rate with this regimen has been similar to the comparator arm receiving continued standard oral therapy. Although cabotegravir/rilpivirine has only been approved for patients with stable virologic suppression, it is increasingly being used for patients who are viremic but have difficulty adhering to oral therapy. Across 18 studies, including roughly 1,100 patients, the prevalence of virological failure in this switch viremic population has been reported to be about 5%. Among individuals who experience virological failure on long-acting cabotegravir/rilpivirine, integrase resistance has been reported in 40% to 70% of cases. In the Atlas and FLAIR trials, 11 out of 180 participants with subtype A6 viruses experienced virological failure. The integrase mutation L74I is present in nearly all A6 viruses and in 3% to 16% of viruses belonging to other subtypes. L74I appears to be weakly selected by INSTI exposure in patients, and it does not reduce INSTI susceptibility. It is unclear whether the risk associated with the A6 subtype is related to L74I, some other aspect of the A6 sequence, or to trial site factors specific to the regions where subtype A6 viruses predominated in the Atlas and FLAIR trials. Rilpivirine resistance mutations detected by proviral DNA sequencing have also been implicated as causes of virological failure and emergent resistance in persons with HIV receiving cabotegravir/rilpivirine. Finally, subtherapeutic cab and/or rilpivirine levels are another risk factor for virological failure. Another major area of interest in long-acting therapy is the use of broadly neutralizing antibodies, or bNAbs. This slide summarizes why bNAbs are exciting candidates, but also why they have been challenging to bring to routine clinical use. bNAbs last for months when engineered with Fc modifications that extend their half-life. bNAbs have both neutralizing activity and Fc-mediated effector functions, potentially enhancing their activity in patients. But bNAbs arise only after years of coevolution between HIV and the immune system, requiring extensive somatic hypermutation, explaining why they have been difficult to elicit by vaccination. Another major challenge is that bNAbs require plasma concentrations hundreds-fold above the IC50, IC80 to prevent breakthrough infection. As a result, only a small fraction of known bNAbs have the potency and breadth required for clinical use. Only 3 bNAb classes have advanced to clinical trials: CD4 binding site bNAbs, V3 glycan bNAbs, and V1-V2 apex targeting bNAbs. Additional major challenges include the limited breadth of activity across HIV diversity of even the broadest bNAbs, difficulty in reliably assessing susceptibility of the viral reservoir to a bNAb, and limited accuracy of current genotypic approaches for predicting susceptibility. These panels illustrate where the major bNAbs bind on the HIV-1 envelope trimer and how broadly they neutralize circulating viruses. These structural images show a side view of the envelope trimer. Black residues represent the amino acids directly contacted by the antibody. Purple residues indicate glycan contacts. Red residues mark positions where mutations are known to reduce susceptibility to that bNAb. Below each structure is a susceptibility distribution for bNAbs targeting that epitope class. Each curve represents many envelope pseudoviruses tested against a given bNAb. The y-axis shows the IC80 values on a log scale. Neutralizing potency or susceptibility is defined here as an IC80 less than 1 microgram per mil, marked by the horizontal line. On the left, you can see that the 3 CD4 binding site bNAbs, 3BNC117, VRC07523, and N6 have the broadest coverage, neutralizing roughly 70% to 85% of envelope variances within the Los Alamos National Lab bNAb database, with IC80 values less than 1 microgram per mil. In the middle are the V3 glycan bNAbs 10-1074 and PGT121, and on the right is the V1-V2 apex bNAb PGDM1400. This slide highlights that while several bNAbs are extremely potent, their breadth varies substantially, and even the best bNAbs do not cover all circulating HIV-1 variants. This slide summarizes 3 phase 2 studies presented this past year of long-acting LS versions of bNAbs in combination with either lenacapavir or cabotegravir. Overall, these regimens were highly promising in maintaining virologic suppression, although small numbers of participants in each study developed virological failure over the course of 12 months. Each trial incorporated phenotypic susceptibility testing of amplified proviral DNA to confirm that baseline viruses were highly susceptible to the bNAbs used. In the study of lenacapavir plus 3BNC117 plus 10-1074, 3 of 53 participants, each weighing over 100 kilograms, experienced virological failure, with resistance emerging to 10-1074 in 2 participants and to lenacapavir in 1 participant. In the EMBRACE trial, combining cabotegravir with N6LS, 4 of 99 participants failed therapy, 2 developed reduced N6 susceptibility, and 1 acquired a major cabotegravir mutation. In ACTG A5357, pairing cabotegravir with VRC07-523, 5 of 71 individuals failed therapy, including 1 with reduced VRC07-523 susceptibility and 1 with cabotegravir resistance. I recently completed a review paper summarizing the genetic mechanisms of resistance to CD4 binding site, V3 glycan, and V1-V2 apex broadly neutralizing antibodies. The review integrated several complementary sources of evidence: envelope contact sites defined by structural studies results from site-directed mutagenesis, mutations selected in animal models and clinical trials, and statistical associations with reduced susceptibility using the Los Alamos National Laboratory Neutralizing Database. This slide highlights the findings for the three major CD4 binding site bNAbs, 3BNC117, VRC07523, and N6. For each antibody, the figure shows the positions that make direct contact, the residues that emerge under bNAb selection, and key substitutions associated with resistance. This slide shows a similar summary for the V3 glycan bNAbs, and this slide shows a similar summary for the V1, V2 apex bNAbs. Unfortunately, genotypic predictors of bNAb susceptibility currently have only modest discriminatory value. As shown in this analysis based on the Los Alamos National Laboratory pseudovirus database, the absence of known resistance mutations increases the probability that a virus will be susceptible to a given bNAb, but the probability remains variable. This part of the slide shows the susceptibility of three CD4 binding site bNAbs having either one or more or zero of the 8 envelope mutations shown at the bottom of the figure. When all 8 mutations are absent, a higher proportion of viruses are susceptible, but that susceptibility is not 100%. In fact, it ranges from 71% to 89%. This part of the slide shows the susceptibility of 2 V3 glycan anti-bNAbs having either one or more or zero of the 2 main V3 glycan bNAb mutations. The presence of one of these mutations nearly always causes resistance to both bNAbs, but the absence does not guarantee susceptibility, with susceptibility reaching 78% for one bNAb and 68% for the other. The last part of the slide shows similar data on the effects of 6 molecular features associated with the resistance on the V1, V2 apex bNAb PGDM 1400. Because of this incomplete predictive power, phenotypic testing will likely remain necessary, at least for the near future, to identify which patients with stable virological suppression are most likely to benefit from a bNAb-containing regimen. This concludes my overview of several recent developments in HIV drug resistance research. Thank you for your attention and for inviting me to give this presentation. If you have questions or suggestions, please feel free to reach out to our group at HIVDB at lists.stanford.edu.